Afternoon, everyone. I'm Dr. Claudia Alene, a member of the ABWP AIM Working Group. It's my pleasure to welcome you to Overcoming Disparities in Black Maternal Mortality, Doctors and Doulas and Mamas, oh my. The Association of Black Women Physicians is committed to improving birth outcomes for Black mothers. You will learn from today's presentation that disparities in Black maternal mortality affect all of us, our families, and our friends. Our goal is to educate providers on the evidence-based benefits of doula support for birthing people. It is our hope that after learning about doula care and the Medi-Cal doula benefit, you will take the information back to your practices and hospitals and support and advocate for full doula integration into your workflows. Some housekeeping issues before I introduce today's presenters. Please mute your microphone. Consider turning off your camera, and if your camera is on, don't forget that we can see you. If you have questions, please place them in the chat. And please complete the program evaluation. We use your feedback to fine-tune and improve the presentation. As an added incentive, you will be entered into a drawing for a $50 Visa gift card if you complete the evaluation. Today's presenters, Dr. Sylvia Swilley and Dr. Jackie Stiff, co-chair the ABWP AIM Working Group. Dr. Swilley is a partner emeritus of the Southern California Permanente Medical Group and is a board-certified pediatric cardiologist. She is a charter and lifetime member of ABWP and a former president of the organization. Dr. Stiff, also a charter member of ABWP, is a physician executive who is board certified in pediatrics and holds a master's degree in public health. Her long career in healthcare management informs her understanding of the challenges and solutions needed for addressing healthcare disparities. And here's take-home message number one. You don't need to be an obstetrician gynecologist to be concerned about Black maternal mortality. Welcome, Dr. Swilley and Dr. Stiff. I turn this over to you.
Thank you, Dr. Elaine, and thanks to all of you for joining us and for this opportunity to speak broadly about the crisis in Black maternal mortality, and more specifically about a doula support benefit, which is now available to all pregnant Medi-Cal recipients and those who've been pregnant in the past year. How that support can positively impact the dire statistics we see. Our goals today are, first of all, to provide background and context for the disparity in Black maternal mortality. We will then define the roles of doulas and the advantages of their support. And then we will detail the state-mandated Medi-Cal doula benefit. Finally, we will describe opportunities to integrate doula care into hospital and practice workflows, and hopefully build on some of these ideas during the Q&A and panel discussion. Our use of the terms mamas and mothers is in reference to and inclusive of all birthing people. Though I will be sharing some statistics and graphs, I don't want us to lose sight of the fact that these are real people with real stories.
When this first happened to our family, I really honestly thought that what happened to Kira was an anomaly. That a woman dying in 2016 in America in childbirth was something that just doesn't happen. We're talking about a woman that raced cars, that ran marathons, she spoke 5 languages fluently. She was a skydiver, she had her pilot's license. Everything she put her mind to, she did. During Kira's pregnancy with Charles, she had a very healthy pregnancy. When she was having contractions, Charles's heart rate began to drop a little bit, so we ended up having to do an emergency C-section, but he was born perfectly healthy and had no complications. She recovered perfectly fine from her first delivery. And so we were ecstatic when we found out that we were welcoming Langston. Throughout her entire pregnancy, once again, Kira was a rock star, and all signs pointed to both Kira being extremely healthy as well as the new baby Langston being extremely healthy as well. Hey, Mommy.
Hi, Daddy.
Hey, Langston.
Hi.
5 minutes away. At our doctor's recommendation, we went into Cedars-Sinai Hospital on April 12th of 2016 for what we expected to be a routine scheduled C-section.
Hey, Langston. I've been waiting on you, buddy. Everybody's here to celebrate.
Langston is born perfectly healthy, 10 fingers, 10 toes. I'm sitting there by Kira's bedside. I look down and I begin to see the catheter coming from her bedside begin to turn pink with blood. I bring it to the attention of the staff. They come in, they assess Kira, they call for several tests, including a CT scan that was supposed to be performed stat. So that was around 4 o'clock. So 5 o'clock comes, the blood work comes back, it's showing that all of her blood levels are abnormal. 6 o'clock comes, still no CT scan. 7 o'clock, now by 7 o'clock, Kira is shivering uncontrollably. 8 o'clock comes, still no CT scan. 9 o'clock comes, and I'm getting the runaround. I pulled a nurse to the side at Cedars and I said, look, my wife isn't doing well. I need help. And the woman looked me right in my eyes and she said, sir, your wife just isn't a priority right now. It wasn't until after midnight that they finally made the decision to take Kira back for surgery. And as we're walking down this hallway towards the OR, one of the doctors says, it's not a big deal. Sometimes these things happen. I'm gonna go back in through the same incision I made earlier. I'm gonna find out what happened. I'm gonna fix it. And she'll be back in 15 minutes. And so we're walking down this corridor, and you finally get to this set of double doors where I just can't go anymore. And they wheeled Kira into the operating room, and those doors closed behind her. And that was the last time I saw my wife alive. There's levels of failure, and there's what you've heard is very much a failure of protocol and procedure and extreme neglect, but there's also this lack of fundamental human decency. There's no reason that Kira should not be here with her sons today. When this first happened to our family, I really honestly
That the U.S. has one of the highest maternal mortality rates among industrialized nations has been reported for decades. But I was surprised to learn in 2018, and what has been given so much attention more recently, is the alarming disparity in African American maternal mortality compared to white women. And just as this slide suggests, the disparity has always been there and persists. I don't know if you are familiar with First 5 LA. First 5 is a county agency founded with tobacco tax revenues. Each county is funded based on the county's birth rate, and each county gets to decide how to use that money to improve the health and welfare of children 0 to 5. I serve as an alternate commissioner at First 5 LA. One goal is to decrease infant mortality and the disparity that has Black babies dying at twice the rate of white babies. Congenital defects is the leading cause of death in the first year, and as a pediatric cardiologist, I'm very familiar with that. Prematurity and low birth weight rank number 2, and maternal complications rank number 5. You might have noticed that Dr. Stiff and I are both pediatricians. It is clear that if we want to give babies their best chance, we need to address mothers' health. In 2018, the Association of Black Women Physicians invited the Los Angeles County Department of Public Health, AIMM, African American Infant and Maternal Mortality Prevention Initiative, to educate us on the subject. We co-sponsored webinars and began a partnership. Though not exactly the messenger you'd expect. After all, I'm a retired pediatric cardiologist. You should know that those who suffer maternal mortality at rates at least 3 times that of white women look like me, minus about 40 or 50 years. Because I only have a limited amount of time, I will give you the Cliff Notes version of the background for today's presentation. But we will share a QR code with references we have curated at the end, and also entertain questions during a panel discussion. So again, please write your questions in the chat. Though the disparity in Black-white maternal mortality is usually quoted as 3-to-1, that is Black mothers compared to white mothers, in some locales and for some age groups, it's as much as 8-to-1. To further lend perspective, see how Black women in the U.S. compare to other industrialized nations. Maternal mortality is reported as maternal deaths per 100,000 live births, and is 3.6 in a country like Germany, which is comparable to the U.S. 23.8 in the U.S., though, as a whole, but see here, 55.3 for African Americans. Though this graph shows the 2020 figures, in 2021, the mortality for Black women was 69.9 and 26.9 for white women in this country. From 2022 to 2023, the numbers went down slightly for all ethnicities except African Americans, which went up slightly. Now, California is among the states that fares better than the U.S. as a whole. But even in California, the disparity persists, as you can see here. The most recent figures in California from 2021 show pregnancy-related mortality for white women is 14 per 100,000, but 49 per 100,000 for Black women. Now, this is the kind of slide I complain about and vowed I'd never include in a presentation, but stick with me. Maternal mortality, as I said, is expressed as the number of deaths per 100,000 live births. See here, the maternal mortality for Black women aged 25 to 34 is 4 times greater for African American women compared to white women, 4 times greater during the prime childbearing years. Though I don't have a more recent comparable table, in 2021, the mortality for Black women aged 25 to 39, as I said, was 69.3, while it was 24.5 for white women. Still a 2.8 to 1 ratio. Mortality for a college-educated woman, Black woman, is 40 versus 25 for a white woman without even a high school diploma. Perhaps even more alarming, the maternal death rate for college-educated Black women is 5 times that of college-educated white women. We can't educate or buy our way out of this crisis. I could go on and on with slides and studies that confirm this. Adding to the tragedy is the fact that more than 75 to 80% of the mortality is thought to be preventable. Timing of death reveals that 22% of the deaths occur during pregnancy, 25% on the day of delivery, but as much as 53% between day 7 and 1 year postpartum. The causes of death vary by ethnicity, but cardiovascular disease has always been a leading cause in African Americans, so late deaths are not too surprising. That's why a close follow-up in the postpartum period is so critical, and missing that postpartum visit can be deadly. Negative birth experience is cited as a reason by Black women that they avoid that postpartum visit. Though we are emphasizing maternal deaths, let's not lose sight of the fact that severe maternal morbidity, that is, severe complications like stroke, bleeding requiring transfusion, infections not resulting in death, occur in more than 70,000 mothers per year, compared to 1,200 deaths, and still the disparity persists, as shown here. Morbidity matters too. We're aiming for more than just not dying. The expectation is a safe, joyful pregnancy. Numerous studies cite racism as a root cause of the increased maternal mortality for Black women. Racism, not race. This information is not just known to the medical community, it is filtered into the lay press, such that some Black mothers express fear of dying in hospitals and look for alternatives. How does racism create a root cause of the disparities we see in maternal health? First of all, racism, systemic racism, creates unhealthy neighborhoods where higher rates of poverty and unhealthy conditions aggravate pregnancies. Access to food and safe spaces is limited. We talk about obesity, especially BMIs greater than 40, as a severe risk factor for maternal morbidity and mortality, and we recommend improved nutrition and exercise. But a mother is unlikely to succeed in communities where access to low cost, high quality food or even a grocery store goes wanting. There isn't equitable access to paid family leave. It has been shown in multiple studies that paid maternal leave results in decreased maternal depression and decreased intimate partner violence, decreased infant mortality, and decreased rehospitalization of mothers, just to mention a few of the benefits. There's inadequate transportation. Consider the consequences when prenatal visits require transportation on the bus, or when a prenatal or postpartum visit is canceled by the provider because the mother is late and she's dependent on public transportation. Racism creates lack of access to quality, respectful care. Mothers are more likely to deliver at poor quality hospitals. Focus groups and surveys, including a 2023 CDC study, reported 30% of the Black mothers referenced neglect and mistreatment compared to 19% of white mothers, which is still a concern. 26 to 28% of those delivering with no insurance or public insurance versus 16% of those with private insurance also reported mistreatment. Complaints included being shouted at or scolded, not responding to requests for help, and not protecting the mother's privacy. Some report being threatened with withholding treatment or being coerced into treatments they did not want. Such treatment leads to mistrust and even PTSD. Discrimination increased the likelihood of the mother not returning for a postpartum visit, which again puts them at risk. Systemic racism can create toxic stress. Stress causes the release of glucocorticoids, cytokines, and catecholamines. Toxic stress magnifies the response several fold and is prolonged. This leads to dysregulation of the cardiovascular, neuroendocrine, and immune systems, and anthropometrics, resulting in chronic diseases like hypertension, diabetes, and obesity, which can complicate pregnancy. It is this pathology, this weathering effect, that many think is in play, creating situations such that even when educated, insured, and with financial means, Black women still fare worse in pregnancy. Racism creates negative social determinants of health, lack of access to quality, respectful care, and toxic stress, a perfect storm for the outcomes we see. The solution requires attack on many fronts, a multi-pronged approach. As physicians, even as we have developed toolkits to address cardiovascular disease, sepsis, hemorrhage, and preeclampsia, and must ensure these protocols are followed in our delivery suites, we must not lose sight of basic services that can be offered to all mothers as a means of moderating the effects of racism. Doula care, though not a panacea, checks off a lot of boxes and is a strategy we should employ. When the Department of Healthcare Services announced doula care as a benefit that would be provided to all birthing people with Medi-Cal, we, ABWP, were eager to get into the fray to ensure the benefit was available to all. Why? Because the victims are not just our patients. They are our daughters, our granddaughters, our nieces, our sisters, ourselves. We are the patients and the providers. We can only hope that private insurers will follow suit and make the benefit available to all pregnant people. Dr. Stiff?
Thank you, Dr. Twilley. So what are we doing in the state of California? State legislation now requires prenatal providers to take evidence-based implicit bias training every 2 years. And California has extended postpartum medical care to 12 months. And more recently, Medi-Cal coverage now includes doula services as a benefit starting January 1st, 2023. Perhaps before going into detail about the doula benefit, it is best to first define a doula, describe the services they provide, and share the evidence of positive impact of doula support on birthing outcomes and satisfaction. Doulas are trained perinatal professional birth companions. They provide physical, emotional, and non-medical labor and lactation support, education and advocacy, and help with the birth plan. Since the postpartum period can be high risk with over 25% of deaths occurring after 42 days postpartum, doula support remains critical throughout the first year. Doulas serve as navigators through the health and social service mazes and provide linkages to community-based resources during pregnancy, delivery, and postpartum. These supports extend to other reproductive experiences such as miscarriages, stillbirth, and abortion. Doulas do not perform clinical tasks such as fetal heart monitoring. They don't give medical advice or make diagnoses. Doulas do not make a decision for the client. Doulas should not pressure the birthing person to certain choices, and they do not take over the role of an intimate partner or a family member. Remember, doctors and midwives catch babies and doulas catch mamas. Birth workers such as midwives and doulas have traditionally occupied prominent positions in African and African American communities as healers and maintain extensive social networks. But what is the evidence that doula support provides benefit, and why are federal and state governments willing to invest these resources? Clinical benefits of doula support include reduced use of Pitocin, yet shorter time in labor, fewer requests for pain meds, and less use of forceps and vacuum extraction, fewer C-sections, and more VBACs, and better APGAR scores. Emotional support, especially if doulas are obtained in the first trimester, resulted in less postpartum depression and anxiety, more positive memories of the experience long-term, and greater satisfaction with the overall birth experience, including improved self-esteem and family bonding. Women who receive doula services are more likely to follow up in postpartum visits and to breastfeed. Some additional information in terms of additional studies show that in one multi-state review of managed care plans, high-risk patients with doulas were compared to patients who did not have doulas. Those with doulas were 2 times less likely to experience a birth complication, 4 times less likely to have a low birth weight baby, and more likely to breastfeed, and also to feel happy about the care they received. So what does the Medi-Cal doula benefit cover? An extended initial visit along with 8 additional visits, attendance in labor and delivery, and up to 2 additional extended postpartum visits. Visits can be performed by doulas during pregnancy, during L&D or labor and delivery, postpartum, but also after miscarriage, stillbirths, or abortions, or even if the individual was pregnant anytime within the past year. There's no place of service requirement. For example, home deliveries are covered, and an additional 9 visits can be ordered by a licensed practitioner. So what are the basic Medi-Cal requirements to become a doula? They must be at least 18 years of age. They should have adult and infant CPR training by the Red Cross or the American Heart Association. They must have HIPAA compliance training, 3 hours of continuing education in maternal, perinatal, or infant care every 3 years. And along with all of this, there are 2 pathways to become a doula, both the training pathway or the experience pathway. We wanted to show you the extent of doula training as paraprofessionals along these 2 pathways. For the training pathway, 16 hours of training in the following areas: lactation support, childbirth education, anatomy of pregnancy and childbirth, comfort measures, prenatal support, and labor support techniques. And doulas must develop and maintain a community resource list, which we'll share an example with you later on in the presentation. Lastly, They must provide a support at a minimum of 3 births before enrollment in the Medi-Cal program. The experience pathway, at least 5 years of active doula experience in either a paid or volunteer capacity in the past 7 years, attestation to skills in prenatal, labor, and postpartum care by 3 written client testimonial letters or professional letters in the past 7 years, and at least 1 from a licensed physician, an enrolled doula, or a community-based organization. Doulas need to support the unique needs of pregnant women, so additional supplemental training is recommended, though not required. And this includes training such as trauma-informed care, cultural sensitivity and competency, implicit bias and anti-racism training, social determinants of health, perinatal mood and anxiety disorders. Obtaining doulas in the first trimester is associated with a decrease in these conditions. Intimate partner violence. Many of us know that pregnancy is a vulnerable time for women. And perinatal loss and bereavement support. Recognizing these needs, doulas are required to have a roster of referral sources. This is another benefit of doula support, not only for your patients, but also to your practices. Now, community resources have existed for decades, but frequently unknown to the medical community. And here's an example of one such community resource list that doulas are expected to have on hand for their clientele. This is a very busy slide, but thought I wanted to give you an example of the list and the depth and breadth of the resources. And I'll point out a couple of areas. The doula hotline is offered through the LA County Department of Public Health Medi-Cal Doula Hub. Individuals can call up to 3 times for services, and that's even outside of a call looking for a doula. Black Daddy Dialogue. Many times dads are left out of the equation, and here are at least 2 groups identified just for dads. And of course, perinatal mental health, which is very important. This is another very critical resource. What's not on the list is something called the Abundant Birth Project, and doulas will know of this as well. This is a pilot that guarantees basic income in counties in California to selected pregnant mamas. And for the LA County, it's been so successful in enrolling their 400 individuals. The program is now full at this time for LA County, but I've noticed many neighboring counties are still enrolling women. It'll be very interesting to follow these women and babies and look at the outcomes as a result of guaranteed income. Also, we learned about a brand new resource the other day called the Black Joy Guide for Maternal Health, and that resource, I believe, is in the chat, where you can download. And this is a resource created by Black Women for Wellness, an organization that is helping women, guide women through their journeys from family planning, pregnancy, and beyond. Dr. Swilley.
There's not just an elephant in the room. There's a small herd that threatens the implementation of this much needed benefit. Thus the title of today's presentation, Doctors and Doulas and Mamas Oh My. First of all, there are not enough doulas enrolled in the Medi-Cal program. Traditionally, doulas and mothers have a self-pay fee-for-service agreement, sometimes on a sliding scale. You should know that for over a decade, some doulas and doula collaboratives have been providing doula support in the community by securing grants for those who could not pay. Yet another reason access to the Medi-Cal system of payment should be available via the experience pathway. The new Medi-Cal doula benefit requires that doulas go through an enrollment. The process is time-consuming at best and an intimidating, complicated bureaucratic nightmare for some. Furthermore, doulas have to contract with each individual managed care organization, and they don't all have the same requirements, processes, or reimbursement. Doulas report significant delays in timely payment for their services. Some doulas are beginning to think it's really not worth enrolling. Currently, there are about 800 doulas enrolled in the state, 85 in LA County when I last checked. The county has established a Medi-Cal doula hub to support community doulas with enrollment, training, quality assurance, and workforce development to meet the demand. Some other doula hubs are now assisting with billing and providing supports related to work-life balance to prevent burnout at a time when we need to grow the workforce. Managed care organizations also have promised to assist with billing and enrollment, but this has not happened consistently and complaints have been registered with the state. Reimbursement. It's important that reimbursement provides a living wage commensurate with the time demands and experience of the doulas, and this has been an issue since the rollout all along, with significant delays in payment. Frequently, it's not appreciated that a doula visit is typically 2 hours versus a 15-minute provider office visit. A doula visit is usually a home visit, so there are transportation costs. The average time of continuous attendance at a delivery for a doula is 18 hours versus 5 hours of intermittent checks during labor by physician providers. Doulas are also on call and respond to texts and phone calls at no additional cost. Doulas do not get benefits, which normally adds about 43% to an hourly wage. Cultural competency is the ability to deliver quality care to diverse populations and requires more than 2 hours of state-mandated implicit bias training. The influence of implicit bias is especially relevant in high-stress areas like the ER and L&D. Fortunately, participation in specific strategies and programs has been shown to be effective in reducing bias, but first it has to be recognized. This might naturally flow into a discussion about racial concordance. Community-based doulas intentionally share the same backgrounds, culture, language, values, and benefits and beliefs of the patients they serve. Traditionally, they are situated outside of health institutions, strengthening their positions as trusted advocates by the patient, but sometimes inadvertently estranging them from the very healthcare teams with which they must partner. It's imperative that managed care organizations and hospitals ensure a diverse workforce and include community-based doulas in their directories. I saw a list of 25 doulas at one managed care organization. Nothing identified them as Black. None of the most prominent and recognized Black doula collectors in LA County were listed in that directory. Perhaps directories should include pictures of the doulas and brief statements by the doulas, as is done in physician and provider directories. The doula work experience in some hospitals has been a cause for concern. The scope of practice of the doulas should not be violated by them, but their expertise, skills, and commitment should be valued, respected, and appreciated. Dr. Stiff shared with you the evidence of improved outcomes. I saw a recent study that showed for prima gravidas requiring induction, C-section rate was over 30% without a doula and 8% with a doula. There's value to the mother and the providers. Some complaints are justifiable and real. Providers have stated in front of patients that various techniques employed by doulas don't work and are unnecessary. Doulas have reported that at times they were not allowed into the hospital, treated as a visitor, not a birth worker, or asked to leave immediately after the birth, and this has been since COVID. I spoke to one doula who shared with me that she was not allowed to come upstairs and had to attend her patient on the telephone from a first floor waiting room. My former colleague in cardiology just last week shared with me that he was called to be in the hospital for the birth of a baby with complex heart disease. When he arrived, there was a heated discussion about who could attend the mother because she had chosen the doula over the father. She should not have been made to choose, even during COVID. A hospital doula policy should be published on the hospital's website and posted in L&D. That policy should be informed by all the stakeholders, OB, L&D, midwives, the ER, NICU, and doulas. It's also recommended that a doula liaison be assigned to address issues in real time. We as providers set the tone and create the culture in L&D. We must lead the effort to integrate doulas into the healthcare team, as the doula is part of the mother's team. I hope we'll discuss that more during the Q&A. Dr. Stiff?
Thank you. Wanted to share with you a list of community doulas and their directories for your information. Thank you. Doulas are not clinical providers, but they are part of the mother's team. Integrate them into your workflow. First, respect and recognize the positive impact that doulas can have, not just for the benefit of the mother, but also the healthcare team. Doulas are a constant companion when nurses and doctors have other responsibilities. Secondly, champion doulas and advocate for their presence in the hospital. Encourage an educational opportunity for doulas to share techniques employed in their practices. One Los Angeles County public hospital elected to bring in a team of doulas for an intensive training session with their physicians, midwives, and medical students. Recommend doulas to your patients. In fact, make doula referral a standing order and include doulas in prenatal visits when the birth plan can be discussed. This is a great opportunity to discuss mutual expectations and to ward off any surprises in the labor and delivery room. Remember, you can recommend a doula even after the baby is born, especially in light of those high rates of postpartum mortality that we discussed. Support hospital orientation and tours to be introduced to your facilities and staff that will enhance those workflows. Some examples we've heard: a local hospital had a networking event for doulas and staff, and another facility invited doulas to be registered and gave them badges for a more seamless integration. In the 2023 article published in the peer-reviewed journal Qualitative Research in Health, a group of physicians, midwives, and nurses were interviewed regarding their experiences in a San Francisco community doula program. I thought it was very insightful that the providers described doulas fostering accountability at multiple levels, including mitigating racism and implicit bias. Also, they believe that doulas help to bridge that gap in services that we mentioned earlier, such as providing continuous labor support. And I love the above quote that's seen here: a doula provides an extra layer of pressure to be my best self. Dr. Swilly.
Very few events in a hospital compared to losing a mother in childbirth. The disparity in Black maternal deaths only magnifies the tragedy. Recognizing the effects of racism and social determinants of health as causative, we as physicians and providers must extend our efforts beyond clinical care and prescriptions. We must address root causes. When I attended the med school graduation of my godson, all physicians in the audience were asked to stand and take their version of the modern Hippocratic Oath, very different from the oath I took almost 50 years ago. It states, "I will remember that I do not treat a fever chart or a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes those related problems if I am to care adequately for the sick." Doula support provides resources that we have neither the time, experience, or assets to provide. I hope you will join in our goal to improving Black maternal health experiences and make doulas part of your team as we reach to be our better selves.
Now we have a list, or we've curated a list of references if you'd like to learn more about Black maternal mortality, and the QR code should take you to this list electronically as well.